All right, we will begin the paper session. My name is John Potts. I'm co-hosting with Dr. Cornell. And the first paper is paper number 12, Effects of a Breast Reconstruction Enhanced Recovery After Surgery Protocol on Pain Medication, Readmission Rates, and Outpatient Therapy Referral Rates, a Matched Case Control Study. Dr. Storer, Polo, Little, Madragano, Rush University. And I believe that this is coming virtually, is that correct? Thank you, Chris.
Hello, my name is Dr. Adam Stoyer. I'm an occupational therapist at Rush University Medical Center in Chicago, Illinois. I did a study with 3 of my colleagues, Dr. Katie Polo, Dr. Lauren Little, and Dr. Andrea Madragano, on the effects of a breast reconstruction enhanced recovery after surgery protocol and that effect on pain medication, readmission rates, and outpatient therapy referral rates, and we employed a matched case control study. So for a little introduction, we created an enhanced recovery after surgery pathway or program, commonly known as ERAS. The goal of our ERAS program was to have pre-admission optimization, to have a standardized set of preoperative and intraoperative medication, the use of pectoral nerve blocks, to have a standard postoperative pain medication plan, to introduce early mobilization, and to have post-discharge home support for the entire breast reconstruction pathway. The pathway was a multidisciplinary team driven by everyone working together to resolve issues that delay recovery. In this study, we compared the type of pain medication, so opioids and non-opioids, the amount of pain medication, readmission rates at 30 and 90 days, and then outpatient therapy referral rates up to 90 days. And we compared patients who were enrolled in the ERAS program versus those who were not enrolled in the ERAS program. So this was a non-experimental study using a retrospective case control design. Data was extracted from January of 2015 through January of 2020, during which 563 women were admitted to the hospital for a breast cancer reconstructive surgery. We assigned 165 patients to the control group who were not enrolled in the ERAS program, and then 165 women to the case group who were enrolled in the ERAS program. The controls were matched to the cases on age within 5 years and having the same type of surgery. The 3 surgeries that we included in this were autologous surgeries, prepectoral implant placement, and subpectoral implant placement. The participants included were at least 18 years of age, female, diagnosed with stage 0 to 3 breast cancer, or high-risk patients undergoing risk-reducing surgery and were admitted to the hospital at least 1 night after surgery. The exclusion criteria included those who had a history of shoulder impairments or pain or prior history of chronic pain being treated with pain medication. For our data analysis, we used SPSS to look at 3 binary logistic regression models. So pain medication refills, it was yes or no to needing an opioid or a non-opioid refill. Outpatient therapy referrals was a yes or a no to a referral generated within our EMR system, and yes or no to a readmission at 30 and 90 days. The objectives or the goals for our ERAS program were to minimize postoperative pain, employ a multidisciplinary approach to the recovery process to improve outcomes, to reduce post-surgical complications, and to decrease the hospital length of stay. All patients received pectoral nerve blocks preoperatively, except for DIEP flaps, which used long-acting local anesthetic. We had a standard post-operative pain regimen that was administered and controlled by the plastic surgeon. Pre-op education was given from one of the oncology nurses, and each patient in the ERAS pathway also received an occupational therapy evaluation and treatment session prior to their discharge home. Here's a table of our demographic data. If you look, the age of the cases group is very similar to the control group, again, because we controlled for that variable, as well as for surgery type. This is a table of the number of pain medication, the number of pain pills. The goal of the ERAS program was to prescribe fewer opioids. So as you can see, the case group got about half the amount of opioids that the control group received. With that, though, the number of non-opioid pain pills went up a little bit in the case group in order to still manage women's pain. Here's the first table of our regression analyses. As you can see, I've bolded the significant results. So women who had left-sided surgery only were prescribed fewer opioid refills and fewer non-opioid refills. And again, this is yes or no to a refill. Women who were older were also prescribed fewer opioid and non-opioid refills. And then women who received an occupational therapy session were prescribed fewer opioid refills. Here is the data surrounding readmission at 30 and 90 days. Again, this is a binary logistic regression model. As you can see, the only thing that was significant was for women who had longer length of stays. They were more likely to be readmitted to the hospital up to 30 days. And now for our last regression model on outpatient therapy referrals, women who had left-sided surgery only were less likely to need an outpatient therapy referral. And also women who received inpatient occupational therapy were less likely to need an outpatient therapy referral. And again, this data was looked at up to 90 days after surgery. So in conclusion, the successful implementation of our multidisciplinary ERAS protocol resulted in women who had left-sided surgery only and older women were prescribed fewer opioid and non-opioid pain medication. Women who received occupational therapy were also prescribed fewer opioid pain medication. Women with longer hospital length of stays were more likely to be readmitted to the hospital within 30 days of discharge, and women who received inpatient occupational therapy and who had left-sided surgery only were less likely to need an outpatient therapy referral. Some of these results are congruent with other studies in the literature, like women who are younger needing more pain medication, the same as with hospital lengths of stays. There are other studies that demonstrate that women who have longer hospital length of stays are more likely to be possibly be readmitted to the hospital. Some of the new findings from this study was that having occupational therapy while women were inpatient also contributed to fewer opioid prescriptions and contributed to women needing less outpatient therapy referrals up to 90 days after surgery.
All right, well, thank you for that nice presentation. This paper will be discussed by Dr. Catherine Runnigan from Texas Tech University Health Science Center. He said. Is this virtual also? Not that we know of. Is the presenter still online? Okay.
Yep, I'm
one question from the audience, at least.
Hi, Stephanie Niemer, Texas Tech, El Paso. I had a question regarding, were these immediate or delayed breast reconstructions?
They were immediate.
Okay.
Hi, Alexis from Denver, Colorado. In regards to the decreased opiate requirements for surgeries on the left, is that because all the patients were right-handed? Was that part of your database, understanding dominant side?
We did not look at hand dominance, but that is in our findings is we do feel like more women are right-handed and possibly use their right arm more, so maybe they would need more pain medication.
Thank you.
Other questions from the audience? All right, well, thank you very much for the presentation. Very nicely done.
Thank you.
Our second speaker is Dr. Kaylin Beitner. The COVID-19 pandemic exacerbates health disparities and assaults. A retrospective analysis of trauma activations 2018 to 2020. also a virtual presentation.
Good morning, and thank you for coming to my presentation entitled The COVID-19 Pandemic, Community Violence, and PTSD in Louisiana. To give you a brief background on the scope of the problem, injury deaths result in more worldwide deaths per year than HIV, AIDS, TB, and malaria combined. If you look at this, there's this image on the right, you can see that there is also a significant difference in the impact of these deaths by specific injury type, homicide and suicide being similar, but being much less than road traffic injuries. And that you can also see that there's a huge difference in the impact on men versus women worldwide. In the United States specifically, that data was from the World Health Organization, there are some significant disparities in racial breakdown of trauma. So nationally, for homicide, it is the leading cause of death for young Black men, which the CDC defines as age 10 to 34 years. And young Black men are actually 19 times more likely to die by homicide than similar age white peers. The total ratio of all young people, male and female, is a difference of 12-fold. So young Black men and women are 12 times more likely to die by homicide specifically than young white men and women. And then in Orleans Parish, where we are in New Orleans, there is no data specific for young people, but all age men, Black men are 8 times more likely to die by homicide. And again, this is just one piece of that graph of all causes of injury, but trauma in the context of violence is really what we're going to be focused on here today. The objectives of our study were to characterize differences in violent trauma at an urban hospital before and during the pandemic, and we did that looking at the rate using negative binomial regression, and then to compare the social disadvantage level of patients with these injuries before and during the pandemic. And for that, we proposed an equivalency test with margins of 15% difference. For our study design, we looked at trauma activations at our institution between March 1st and August 31st in 2018, 2019, and averaged those as our pre-COVID numbers, and then during 2020. For trauma intent, we took that from the chart using the ICD-10 codes. Whenever there's a trauma activation, it's classified as either an assault, an unintentional trauma, self-harm, or undetermined other, and that other category is less than 10% of cases. And then to assess social disadvantage, we use the area deprivation index, for which you can see the image on the right. Areas that are considered less socially deprived are more blue, and areas with higher levels of social deprivation are red. And these categorizations are based on the American Community Survey and the US Census Bureau data. And so Dr. Kine's team out of University of Wisconsin just aggregated that data and standardized it across the country. So our first objective, again, to characterize differences in violent trauma before and during the pandemic. Overall, we found a 21% increase in violent trauma, as well as an increase in the relative proportion of assault trauma. So out of all traumas pre-pandemic, it was about 1 in 4, and it went up to 35%. Here you can see our table of the data before and during the pandemic. There was no change in the gender, so men were still more likely to experience any sort of trauma. There was no difference by race, but there was a difference by injury intent, of course, as described on the previous slide. And there was no change in age, survival status, or GCS upon presentation to the hospital. This is the data for our negative binomial regression. As you can see, there was a 22% increase in all traumas overall, but then between the pre-COVID and the COVID period. But then when you look at who is experiencing that, you can see that it is men who are driving that increase. It is Black individuals who are driving that increase, and then it is Black males who are most likely to experience assaults. And so this isn't all trauma, this is specific to assaults. For our second objective, we wanted to see if there is a change in the health disparity, like people who are experiencing these traumas, is the increase in violent trauma being spread all across the board, or is it impacting the same people who were previously experiencing violent trauma? We found that the latter was true. There was no change in the ADI rating among patients who experienced violent trauma before versus during the pandemic. You can see that here with our equivalence p-values. So these p-values in red are the significant ones. And the way to interpret this table would be that if a value is significant at the 5% level, that means that the ADI really didn't range at all beyond a 5% confidence interval. And so again, just as on the previous slide showed, there's no change overall in the ADI rating down to 5%. We had to hypothesize 15%. And again, this is driven by increase in assaults among a persistent category of Black men. So in summary, as mentioned, there's an increase in total assault volume, but there's no change in the social circumstance of the patients who are experiencing assaults in our area. This drives the need for better prevention at the primary, secondary, and of course tertiary levels. And so overall, we know that the pandemic has had a huge impact on gun violence in our area and in assaults, and we need more interventions to address them. Thank you.
Paper will be discussed by Paul Bjordahl from Sanford Health.
Thank you. Dr. Beer, congratulations on a thoroughly evaluated study of your trauma population, where you demonstrated and quantified the increase in violence in your local community during the COVID surge in 2020. I think anecdotally, this is a pretty common experience in basically every trauma center I've spoken with anyone who works in nationwide. Your study specifically attempted to find the association level of social disadvantage as a risk factor based upon home address and of the patient or by race to potentially identify shifts in the demographics of injured, assaulted patients. So I really have one clarifying question and then one area I'd hope you could comment on a little bit more. Number one, overall, this is a relatively uninjured patient population, ISS of 4. Were you able to exclude the possibility of volume shifts from other nearby non-trauma centers or ambulance triages, et cetera, based on diversions from COVID and things like that? And number two, could you comment a little bit, the area of deprivation index, which I had to learn a lot about in the last couple of days. It's presented as a static number, but the premise of the paper is that ADI is going to acutely shift based on economic factors causing social stresses. And so we saw an increase in your white male injured population as well from assault, and an increase in their ADI that almost approached that of your Black patients. And so would you comment that perhaps is ADI a good predictor of sensitivity to social stressors such as that?
Yeah, so to answer your first question, there aren't a lot of other hospitals in our area. UMC is really the only level 1 trauma center for the greater Southeast Louisiana region. And most ambulances, that's their go-to, is that they bring all patients with violent injuries to us. So there could be some bias in if patients with a walk-up injury didn't come to us, but we're also the only safety net hospital. So I would suspect that we have a pretty robust sample that is quite inclusive. To your second question, I think the ADI is a good measure. It encompasses 17 different variables from the ACS and from the Census Bureau. It's not perfect. The premise of our study is that areas with higher social disadvantage are more susceptible to the changes that accompanied the pandemic. So increases in financial instability, housing instability, social isolation, et cetera. But I think it'll be pretty interesting to see as more data comes out from the 2020 census, it might capture some of those changes because the ACS is incorporated into the census. And so having that full data set, it'll be really neat to see how things change and how even our analyses change based on the current version of the ADI versus the subsequent one.
Nice job. Thank you.
Thank you.
I want to ask one other question. You attribute the cause of this to the pandemic. Did you rule out other causation? Were there, for instance, extended civil uprisings after the George Floyd murder? Were there there were a number of mass shootings in Louisiana during the year 2020. Were any of those in Orleans Parish? Did you look at other causes other than the pandemic that might have influenced this increase in violence?
So we've toyed around with that idea. I don't think the number of mass shootings increasing would have swayed us in our data set, because it would have, if it were a significant factor, then it would have changed that injury severity score as well as the GCS. In terms, like if it were an influential factor, then we would have seen a pretty big shift in more severe injuries. There weren't a lot of injuries related to the protests in our area. And so if you mean like some sort of change in racial tension, then that I guess could have occurred, but anecdotally in our area, that wasn't a factor. It was, or at least it was not reported on by the news, and it wasn't something that we noticed within our patient demographics of reporting of like, I was injured by a hate crime.
Okay, well, thank you. I don't think we see any questions from the floor. I'm sorry you couldn't come out and enjoy the sun and the water, but I know you got plenty of water in New Orleans. So
Yes.
we do appreciate your presentation this morning. Thank you.
Thank you all.
Next is paper number 14, graft repair of arteriovenous fistula aneurysms is associated with decreased long-term patency. Chang, Haina, Taranella, Charvinsky, Hollinger, Jensic, Olayton, Hertel, and Chan, and Ms. Chang will present.
Do you mind if I take my mask off
Please.
to present? Okay, just want to make sure. All right, good morning, everyone. I wanted to start off by thanking the Southwest Surgical Congress for allowing me to present in beautiful Maui today. I am a fourth-year medical student at Rush, and I did this with the transplant department at our school. Okay, and we have nothing to disclose. So according to the CDC's reports this year, about 15% of adults in the United States are affected by chronic kidney disease. In 2020 alone, last year, there were 90,000 patients waiting for a kidney transplant, while only 20,000 received one. Due to the scarcity in available organs, there are thousands and thousands of patients on dialysis, the most common of which is hemodialysis via an arteriovenous fistula. Because these patients are on long-term hemodialysis, one of the long-term complications of having an AVF is the formation of arteriovenous fistula aneurysms. These can be painful, they can be disfiguring, and importantly, they can risk rupture, which can result in life-threatening hemorrhage. Thus, surgical repair is often indicated in these patients. At our institution, there are several techniques for AV fistula aneurysms, but the three most common are aneurysmorrhaphy, where a lens-shaped segment of the vessel is longitudinally excised and the vessel is reapproximated to a smaller diameter. Excision of the entire aneurysmal segment followed by end-to-end anastomosis is usually done in patients with quite redundant vessel. And finally, synthetic graft interposition is typically reserved for patients with very poor vessel integrity. The Fistula First Breakthrough Initiative back in the early 2000s advocated for benefits of utilizing native tissue over artificial grafts for primary access. However, this has not been explicitly studied in the setting of AVF revision surgery. So we sought to answer the question in patients with symptomatic arteriovenous fistula aneurysms requiring surgical revision, do patients who undergo synthetic graft bypass to have decreased long-term patency as compared to patients who undergo autologous vessel repair? So to answer this question, we started by identifying that all the patients that underwent an AVF aneurysm repair at our institution between the years 2009 and 2019. We excluded patients that underwent a two-part staged repair approach for multiple AVF aneurysms. We also excluded patients that had a primary graft at the time of aneurysm surgery. And we also excluded patients who were already status post kidney transplant or another AVF placement, or were otherwise not utilizing their fistula for hemodialysis at the time of surgery. We ended up with 87 patients in the aneurysmorrhaphy group, 50 patients in the end-to-end anastomosis group, and 25 patients in our graft repair group. So starting out with demographics, we found that the mean age among the three groups was comparable in the early 50s or so. We also found that the majority of patients in all three groups were male, with no significant differences between the groups. We also looked at current smoking status and a couple comorbidities, including diabetes and hypertension, and we found these to be comparable between the groups as well. Next, looking at some characteristics of the AV fistulas themselves, we found that the mean time from fistula placement to aneurysm presentation was about 7 years, which was comparable between groups. At our institution, we do routinely perform fistulography preoperatively for these patients, and we found significantly higher rate of central stenosis in the graft repair group at 56% compared to 33% in the aneurysmorrhaphy group and about 28% in the end-to-end group. This may be due to the fact that outflow stenosis contributes to weakened vessel walls, thus rendering autologous repair difficult in this group, the graft group. We also looked at the percent of thrombus and percent of calcified fistulas reported in the operative reports by the attending surgeon, and there were no differences between the three groups in those regards. To examine outcomes, we performed a multivariate logistic regression controlling for confounding variables and found that compared to patients in the aneurysmorrhaphy group, which we used for reference, those who underwent synthetic graft bypass had a 3.4 times increased odds of losing primary patency within the first year of surgery. We also found that these patients were at almost a 6 times higher likelihood of developing an infection at the fistula site within the first 3 months after surgery. Another outcome that we examined was the likelihood of forming a secondary aneurysm down the line, and found there were no differences between the groups. Finally, we used Kaplan-Meier estimate to illustrate the longevity of these fistulas after aneurysm repair surgery. And as you can see, the synthetic graft group here in the green exhibited significantly greater loss of patency compared to the other two groups here. Notably, over 30% of these patients completely lost their access within the first 6 months after surgery. So in conclusion, our study suggests that the use of bypassing synthetic grafts for AV fistula aneurysm repairs was associated with decreased primary patency, increased infection rates, and decreased long-term access compared to the two autologous repair techniques that we studied. And this suggests that artificial grafts should be used judiciously and only in patients with very poor vessel integrity where it's not possible to salvage the native tissue, and should be done with the knowledge of the associated high rates of access loss and infection. And thank you so much for your time and attention. I'll be happy to take any questions or comments.
Discussion of this very nicely presented paper will begin with Josh Gearman from University of Oklahoma.
Yeah, Jamie, very nice job on your presentation. Congratulations. I think you asked a very important question with the study, particularly because although, hemodialysis is meant to be a transition to transplant, we know a lot of patients that is not a reality for them. And you showed that compared to aneurysmorphia and aneurysmectomy, graft interposition is inferior and leads to a higher rate of access loss. My question has to do with central stenosis and these patients. Your interposition group had a significantly higher rate of central stenosis. Did you look at central stenosis as an independent risk factor for access loss?
We did not. We actually, in our multivariate regression, we use that as a control, or we looked at it as one of the confounding factors for access loss, but it would also be interesting to switch up our analysis and look at it as a risk factor, an independent risk factor.
What?
Thank you for that suggestion.
You might be able to have a paper that says central stenosis is associated with access loss after revision of AV fistula.
Yeah, certainly. Thank you.
Dr. Moore.
Moore, Denver, very nice presentation. There are some more subtleties to aneurysms, I'm sure you know as a fourth-year medical student. One is the size and two is the location.
Yes.
The aneurysms in the forearm are particularly difficult to reconstruct because of the fragility of the vein and the cross circulation of the arterial system. So did you look at the location as well as the size of the aneurysm? And your point about the central stenosis is very critical because as these patients come back to the clinic and you start to see aneurysmal formation, you got to get a fistogram and dilate that proximal stenosis. Otherwise, they all progress to this disastrous aneurysm.
Great.
Great job.
Thank you. Those are two very important points. We did look at the location of these fistulas, and they were all around in the forearm area. We did not, that is one limitation of our study. There were no records of the size or the diameter of the aneurysms or the thickness of the vessel walls. That would have been very interesting to look at as well, but we did not have that data.
Other questions from the floor? Thank you once again. Very nicely done.
Our next paper is Peas in a Pod, clustering minorly injured trauma patients together during their hospitalization results in decreased hospital costs and fewer inpatient complications. It will be presented by Zachary Bauman from University of Nebraska Medical Center.
Alrighty, I want to thank the Southwestern Surgical Congress for allowing us to present our research today. The authors have nothing to disclose. So performance improvement is a significant part of the foundation for many trauma centers around the country. Traditionally, trauma surgeons have been very critical on themselves about reviewing their complication rates. And furthermore, trauma patients can be very complex to manage. Oftentimes because they are multiple system injury, their socioeconomic status, their insurance status, and because of patient perception. No patient ever wakes up in the morning and says, hey, I'm gonna go crash my car today and wind up in the hospital for the next month. And so that can be a challenge for those patients just from a psychological standpoint. The goal of most trauma centers is to decrease complication rates as well as inpatient costs, but how do we go about doing that? One of the ways is recognition of specific categories for complications that can be targeted to hopefully prevent those from occurring, or once they're recognized to act on them quickly and hopefully slow their progression. One is the psychologic factors from care providers. If you're a nurse on the floor and you're not used to seeing a trauma patient and you walk into the room, your psychological effect based off of what you're seeing from that patient's trauma can trickle down to the patient and definitely affect the way their recovery, either both positively or negatively. And lastly, implementation of trauma management protocols. It's much easier to implement a protocol if you have patients grouped together in a certain area of the hospital as opposed to scattered throughout the hospital and trying to affect protocols on multiple levels, on different floors, different settings. So in 2017 at the University of Nebraska, we implemented a trauma unit. And here we have nurses that are trained in trauma care, as well as we have ongoing education for these nurses on a monthly basis. And then we've also implemented trauma-specific protocols on that trauma unit. What we wanted to look at, though, was how this affects the care of these patients in terms of throughput, complication rates, et cetera. And what we found in the literature was that there was very little literature actually specifically examining these complication rates and the cost analysis of when we do group these trauma patients together. So our purpose was to explore these benefits of clustering these minorly injured trauma patients together, with the hypothesis being that complication rates, as defined by the Trauma Quality Improvement Project indicators, and hospital costs would be decreased. So this was an IRB approved retrospective review of all of our trauma patients from January of 2017 when we implemented the trauma unit through January of 2019 at our academic level 1 trauma center. Ages were 18 to 99, and we did exclude patients that were admitted to the ICU, just given the complexity of those patients, either at the onset of their admission or if they were transferred to the ICU at some point during their hospitalization. And then we also excluded pediatric trauma patients for now. We divided our patients into 2 cohorts, those that were admitted to the trauma unit, and then those that were admitted to a non-trauma unit. Basic demographics were obtained, and our outcomes of interest were direct costs, complication rates, hospital length of stay, inpatient mortality, and discharge location. We used student t-tests and chi-square were utilized for dichotomous categorical variables, and linear regression modeling was performed with direct costs as the outcome variable of interest, and significance was set at a p-value of less than 0.05. So when we look at our patient population, we had 1,481 patients in total. 684 were admitted to the trauma unit, and 797 were admitted to a non-trauma unit. In terms of age, the patients that were admitted to a trauma unit were a little bit younger, 49 versus 53 years old. And this was statistically significant. But when looking at the injury severity score, as you can see, the majority of them were minorly injured. Obviously, that's part of the title. But those patients that were more severely injured, those few that did have an ISS greater than 15, they were preferentially admitted to the trauma unit. If you look at the payer source is pretty much the same amongst the 2 groups, with Medicare patients being a little bit higher admitted to the trauma unit. Looking at our outcomes, hospital length of stay there was no statistical difference between the total hospital length of stay of these patients, and mortality was very low between the 2 groups, 2 in the trauma unit and 1 in the non-trauma unit, but this is to be expected given the minorly injured patient in this patient population. When we look at complication rates, however, if you were admitted to a non-trauma unit, you did have a statistically significant higher chance of developing a complication, once again defined by the TQIP indicators. And direct hospital costs were also significantly higher if you were admitted to a non-trauma unit. And that's despite the length of stay being similar amongst the 2 groups, which is oftentimes a driver of hospital costs. When we look at the discharge location, the majority of patients that were admitted to the trauma unit were discharged home, and this was higher than those that were admitted to a non-trauma unit. And patients that were admitted to a non-trauma unit were significantly admitted or discharged to a nursing or rehabilitation facility. When we held the discharge, payer source, hospital length of stay, ISS, and age constant, we found that in our linear regression analysis, if you were admitted to a non-trauma unit, you had a predicted direct hospital cost increase of $766, and this was statistically significant. Limitations, obviously, this is a single center review, and so complications can be defined slightly different amongst institutions, and the TQIP does allow for that. And so therefore, protocols may differ between institutions in terms of how you manage complications or different protocols that you have in place to hopefully prevent complications. This was a retrospective review, and we did exclude the ICU and the pediatric patient population, just given their complexity. And that's definitely something that we're looking to do in the future. But overall, If you have a dedicated trauma unit, it does result in decreased patient complication rates, decreased direct patient costs, and a higher likelihood for discharge home. And our recommendation would be hospitals should attempt to group minorly injured trauma patients together when possible. And with that, I want to thank again the Southwestern Surgical Congress for allowing me to present. I open it up for my discussant and any additional questions.
Paper will be discussed by Grace Ng from Texas Tech, El Paso.
Morning. Congratulations to the authors for this well-written paper discussing the benefits of clustering trauma patients in the same unit with decreased costs, complications, and the ability to discharge patients home. I'm sorry. So a couple questions that I have. The first is how many patients does your trauma unit hold? And in the current setting, it's almost a luxury now to be able to have all our patients clustered in the same place with shortage of beds. And the question would be to ask you how y'all have been able to maintain your trauma unit. Secondly, in your paper, you mentioned that you noticed complications more so in your non-trauma unit versus in the trauma, which would be expected. But just looking at your analysis, were you able to hone in on which complications occurred more in the non-trauma unit? And in the patients in your trauma unit that had complications, were those with the people with the ISS scores of greater than 15?
Thank you so much for those comments and questions. To answer your first one, our trauma unit holds 32 patients, and that's if they're all single bed units or rooms. We actually have the flex to go to double bed, so it could hold twice as many. And right now we currently are doing that because our numbers are significantly high, as are many across the country. When it comes to maintaining the trauma unit, one of the reasons that we did this study is because we always get a lot of pushback about, when we have an open bed on the trauma unit and trying to transfer a patient from a non-trauma unit to the trauma unit, we get a lot of pushback from our bed desk group. And so we try hard, the bed desk actually does a pretty good job now of understanding our need to try to admit trauma patients to that trauma unit, but it's still, obviously we still have patients that are scattered throughout the hospital, and it's difficult during this time. It's more just trying to find a bed at this point in time, given the high volume at our institution. In terms of which complications that we noticed in these patients, that's actually something that we're diving into a little deeper right now, because I do think that that's a very valid question. Obviously some of these complications cost more money than other complications to the patients. A simple UTI might result in not that much to care for that. But if you have somebody that develops bad nosocomial pneumonia, and they might be in the hospital for an extensive period of time, and that may result in some of these variations. So that's something that we're looking into. And also we're diving in deeper into those with an ISS greater than 15. Were they the ones that were the culprits for the increase or the complications on the trauma unit side? That's a great question as well, but something that we're diving deeper into right now.
Nice job.
Yes.
More Denver, I would ask you your opinion. I suggest that the hybrid model may be optimal for this. In other words, have a hospitalist embedded into the trauma service, because most of these patients' discharge is based on non-surgical problems. Disposition, as you point out here, is a huge problem. So why not make a transition ward in which the hospitalist is in charge of getting those patients out of the hospital and have the trauma surgeon see those patients every day to prevent the risk of complications?
I think that's a great idea. And we do try to get some hospitalists involved, mostly in our geriatric patient population, but I think that it's beneficial for all patient ages. And I think that's something that we could definitely work on. It's hard. I'm not going to say that our administration is going to necessarily dive right in and allow us to do that, but I think that that's a great idea.
Albrecht, Oklahoma City. The question kind of dovetails off of that is your charge or cost difference. What was that? Was it linked stay? Was it on the additional testings? radiology labs or things like that that were ordered more on the non-trauma service or unit as opposed to the trauma unit? And could you cut those down by having, similar to what Dr. Moore said, having a surgeon in there so less of that is done?
No, that's a great question. Thank you for that. We haven't been able to figure that out quite yet. It's costs at a hospital, or I'm sure that you guys are all pretty aware, they're extremely challenging to try to figure out exactly where they're coming from. And so we're still deep diving that to try to figure out exactly where these costs are. Because most of the time when I've done studies that look at costs, it's been related to a hospital length of stay. And in this situation, it's not. And so we're trying to figure out exactly where that's coming from. You know, is it the number of complications and why, which complications and why is that complication occurring? Is it just happen to be a red herring in this study? So that's something that we're looking into a little more.
And then the next thing, did you look into the following of your protocols? So if you had a protocol for VTE prophylaxis, were those patients on the non-trauma unit following that same protocol as the one that's on the trauma unit? And were there more VTEs?
Yeah, no, absolutely. That is something that we're also looking into as well. And I can tell you that on the non-trauma units, just our VTE prophylaxis, it's difficult to follow. One of the cultural things at the University of Nebraska Medicine is that the nurses like to hold the VTE prophylaxis the day of surgery, and we've been really trying to educate, because that's actually outside their scope of practice anyway. And so we've really been trying to educate and change that culture. And so I know that when we're not on the trauma unit, that is not being as followed, or that is not followed as precisely as it should be. And now that we've had the trauma unit, we've been able to implement that, and the nurses are aware that they should not be holding that the day of surgery. And so that is definitely something that we're looking into.
Thank you.
Avi Bavaraju from Arkansas. Beyond clustering these patients in an area where they have nurses and staff that are used to caring for trauma patients and having protocols and guidelines, does your trauma unit provide any enhanced level of monitoring? So are they on telemetry? Do they have shorter or smaller nursing staff ratios? Like, is there an enhanced level of care? And the reason I ask this is, in Arkansas, we have our trauma unit as well, but it sort of functions like a step-down unit. So it gives us a little bit more offloading from the ICU, provides a little bit more enhanced level of care. They're all on telemetry. So I'm curious if you structurally have those things in place when you plan the trauma unit.
Yeah, no, that's a great question. So we do have, it's still a work in progress, but we do have the capability of doing a little bit more on the trauma unit. We have telemetry. You know, the nurses are educated. One of the things I'll use an example is the administration of TPA through a chest tube. So we actually have the capabilities of doing that on the trauma unit, as opposed to the rest of the hospital where they have to transfer that patient to like a progressive care unit in order to administer the TPA through a chest tube, just because of lack of experience. And so I think that as we continue to develop our trauma unit, like these protocols, we'll be given a little bit more flexibility and a little bit higher level of care there to be able to do some of the things that we need to from a trauma perspective.
Thank you.
Real quick, one of the things in your data that surprised me was the age difference and the discharge difference. So it sounds like the non-trauma unit has much more geriatric patients maybe. Did you look at the patient frailty and how that both affected the discharge, the cost and the complications?
Oh, we didn't break the frailty down and look at that, but I do agree that, you know, they're a little older that are on the non-trauma units, and that's obviously something that we're also looking into a little bit closer as well as we move this project along. But thank you for the question.
Thank you very much.
Thank you.
Paper number 16 is outcomes of laparoscopic ventral hernia repair after liver transplantation, presented by Hahn, Johnson, Jogrist, Calderon, Hewitt, Pearson, and Harold, Mayo Clinic, Arizona. This will be presented by Dr. Hahn, and it is eligible for the Jack Barney Award.
Hello, my name is Garam Han, and I'm one of the Mayo Arizona PGY4s. Thank you for this opportunity to present our research on laparoscopic ventral incisional hernia repairs after liver transplantations. In 2019, there were 8,896 liver transplants performed in the US. Liver transplant recipients have up to a 43% lifetime risk of developing an incisional hernia. These hernias tend to be large, complex, and debilitating to the patient's quality of life. Historically, open repair was the preferred approach for large hernias. There is literature to suggest that laparoscopic repair is safe and effective with superior outcomes in regards to hernia recurrence, mesh infection, length of hospital stay, operative time, and major complications. However, there's a paucity of data studying laparoscopic ventral hernia repairs in the liver transplant population. Therefore, our high-volume transplant center sought to investigate the short and long-term outcomes following laparoscopic ventral hernia repair in liver transplant recipients, including associated morbidities, length of stay, hernia recurrence, to demonstrate if it is a safe and effective option for hernia repair in this population. A retrospective chart review was performed of all patients with prior liver transplantation who underwent laparoscopic ventral hernia repair at their transplant incision site between January 2007 to April 2020 at Mayo Clinic, Arizona. Descriptive statistics was used to analyze demographics, procedural details, length of stay, complications, and incidence of hernia recurrence. Logistic regression, chi-square, and Fisher's exact test were used to analyze potential predictive factors for developing a hernia recurrence. In brief, the laparoscopic ventral hernia repair was performed using 3 ports in the left lateral abdomen and an additional port in the right lateral abdomen or midline as needed. Spinal needles were used to measure the hernia defect, and a PTFE gore dual mesh was trimmed to allow at least a 4 to 5 centimeter overlap. Gore-Tex transfascial sutures were placed and it was tacked circumferentially. A total of 89 patients met inclusion criteria, of whom 82% were male and 18% were female. Mean age was 60 and mean BMI was 30.2. For immunosuppression, the majority were on tacrolimus and a third on mycophenolate mofetil. The average Charlson comorbidity index score was moderately severe at 4.2, and the average MELD score was 14.9. The most common comorbidities were hypertension, chronic kidney disease, diabetes mellitus, and hyperlipidemia. The liver transplant operative reports for 85 patients were available and included 61 with a Mercedes incision and 24 with a bilateral subcostal incision. The majority were closed with looped OPDS in 2 layers. 21 patients had post-transplant ascites, and 18 patients required reoperation related to their liver transplantation, 2 of whom had a fascial dehiscence. 7 patients had a surgical site infection, and 7 patients had acute rejection treated with a course of steroids. The median time from liver transplantation to hernia repair was 16 months. The average mesh size placed was 743 centimeters squared, and the median operative time was 102 minutes. None required conversion to open. The mean length of stay was 3.7 days, and the median length of follow-up was 21 months. 55% had no complications, and there were no 30-day mortalities or graft rejections. Readmission occurred in 7.9% of patients. The most common perioperative complications were ileus, acute kidney injury, and pneumonia. Intra-abdominal hemorrhage occurred in 1 patient and required reoperation for control of bleeding. There were also post-operative complications related to the hernia repair itself. 3 patients were treated for a surgical site infection. 2 patients had mesh infections, 1 managed non-operatively, and 1 requiring mesh explantation. 4 had hematomas. Progress forward a little quickly. 4 had hematomas, all of which were successfully managed without intervention. 14 were recorded to develop a seroma, of which 3 required aspiration, and the remainder resolved without intervention. One patient complained of chronic postoperative pain, which resolved after trigger point injection. And after a median follow-up of 21 months, incisional hernias reoccurred in 4.5%. The time to hernia repair, Charlson Comorbidity Index score, MELD score, BMI, operative time, mesh size, the type of immunosuppressive medications used, male gender, and the presence of complications after transplantation were all found to not be predictive of hernia recurrence. Our study was not without its limitations. The retrospective chart review introduces a possibility of data entry misclassification. Since our institution primarily manages these hernias laparoscopically, we were unable to directly compare our approach with other techniques. In addition, the repairs were performed by only 2 surgeons, which offers a benefit of consistency from one operation to the next, but could limit the generalizability of our outcomes. Although our study included the largest cohort in the current literature, hernia recurrence rates were low, and thus our study was underpowered to conclusively detect associations between potential predictive variables and the likelihood of hernia recurrence. In conclusion, liver transplant recipients often undergo incisional hernia repairs within 1 to 2 years of their index operation. Although the hernia defects are often large and complex, and the comorbidities in this population are significant, laparoscopic ventral hernia repair can safely and effectively repair these defects with low rates of recurrence and complications. Further studies are needed comparing outcomes of patients undergoing laparoscopic ventral hernia repair to other techniques such as robotic abdominal wall reconstruction to help guide the care of these complex patients. Thank you.
Discussion of this paper is to be opened by Dr. Mentor Ahmedi, Sanford Health, University of North Dakota.
Hi. Hello, everyone. Good morning. I would like to thank the program committee for inviting me to review this great paper by Dr. Han and her group in Arizona. The authors in this group present the largest to date retrospective case series in laparoscopic ventral hernia repair after liver transplantation, which, as we know, is a very difficult group of patients to manage. Even though they only followed the patients for a short follow-up period, the group's recurrence rate mirrors the best other studies in literature done within the same technique, with a recurrence rate of only 4.5% and very comparable other complications during the 21-month median follow-up. During this time, the complication rate was no different than the open group or comparative group. My questions to you are, your group has identified a sample size of only 85 patients that had the operative notes, but we don't know the pool of all the transplants done for liver at your institution. So do you know what the entire group of transplant patients is that you've identified these 89 patients from? That would be my first question. I'll move on. I have a couple of comments and then we'll take it from there. My other question and clarification is, your study used a logistical regression in the 4 patients with recurrence, and this is a very small sample size for that. It appears that on the logistical regressions, you have excluded the sex of the patient and also the immunosuppression regimen, which probably would be very good to include to see if you can find a predictive model in these patients. And has your group considered to do a maybe multi-center comparative study between outcomes in laparoscopic versus open repairs in these patients, seeing how your cohort only includes laparoscopic within your hernia surgeon group?
So to address the first question, thank you for your comments, first of all. Our study was trying to identify the patients who developed an incisional hernia. We did not actually look back to find out the total number of liver transplants that occurred during that time period. So unfortunately, our data analysis did not include the incidence of hernia formation within our liver transplant population.
In addition, some of the laparoscopic ventral hernia repairs in liver transplant recipients that was performed, the patients had their index liver transplant at another institution. So our population, looking at the incisional hernia group, was a mixed group, including the majority from our transplant center, but also a minority that had been transplanted at a different transplant center. As far as the question regarding looking at immunosuppressive medications and whether that had any effect on hernia recurrence, we actually did study that using chi-square and found that there was no significant impact of immunosuppressive medication on hernia recurrence. Sorry, what was your third question?
My third question was, did you consider maybe doing a multi-center trial, seeing how your group only does laparoscopic repairs to compare the outcomes, since there's nothing in literature that directly compares the outcomes of open versus laparoscopic repair in liver transplant incisional ventral hernias?
We actually did not consider doing a multi-center study, but I do think that would be very interesting, especially to just get a bigger pool of patients to study. A lot of the case series before ours, like you mentioned, are quite small, and therefore the data is not as strong as it could be if a multi-center trial or multi-center study was performed. So I think that's a fantastic idea.
Thank you so much. Great
Thank
presentation.
Dr. White?
Yes, congratulations. That was really nicely presented. I find the conversion rate of 0 to be almost incomprehensible. These are complex patients who've had a giant operation at least once before in their abdomen. How is that possible? And is it real? Are you confident that you captured in this retrospective analysis all of the attempted cases laparoscopically, that then are you sure there aren't some in there that got converted to open at some point? You just missed those.
So the way we identified our patients, we have a system where all of the operative reports are put in this database, and all of the operative reports can be searched by certain codes. So we used the codes that indicated someone was getting any kind of hernia repair, and that included actually inguinal hernias, umbilical hernias, and then we sifted through all of those patients to identify which ones had definitely had a liver transplant and which ones were getting the hernia repair for an incisional hernia. So we spread our net quite widely at the beginning in order to try and capture any that may have been missed. So I can confidently say that of all the incisional hernia repairs and liver transplants, none of the operative reports mentioned conversion to open.
Hi, Hunter Moore from Denver, Colorado. I would say after operating on a bunch of redo liver transplants, you'd be miraculously surprised at how few adhesions these people have because they're immunosuppression. So starting laparoscopically seems like a great way to progress this, and making a smaller incision in these guys is a big deal for post-operative recovery. My question was in regards to immunosuppression. When you guys categorized them on what type of immunosuppression they're on, was that when they went into their operation or what they were on long-term? Because a lot of patients, when we do these elective operations, will transition them off their mTOR inhibitors and then restart them on them after a month or so after their redo operation, wherever they're getting.
So we were looking at the most recent liver transplant progress or clinic follow-up note to figure out what their regimen was prior to the incisional hernia repair. So if they had been stopped on a certain medication, months in advance, I think we would have missed it. But most of those visits were, within 1 to 3 months before. So we captured any medications that they were on about 1 to 3 months before and during the hernia repair.
Yeah, you mentioned that there's 2 surgeons that do this operation. Do they have a protocol that they follow for immunosuppression, or is it just whatever they come in, they stay on?
As far as the immunosuppressive medications, we leave it up to the transplant team to determine what medications they feel would be safe to continue. So from the hernia surgeons do not dictate the immunosuppressive medications. We leave that to our transplant colleagues.
Yeah, great talk, thanks.
Very nicely done. Thank you.
Thank you.
Thus endeth scientific session number 3. We have a break. Please return at 9:45 for scientific session number 4.